Good morning, good afternoon, good evening. It's a pleasure to be here and share with you some ideas on the clinical pharmacology of integrase inhibitors. So these are my potential conflict of interest. I just wanted to introduce the structure and the names of the integrase inhibitors that we have in clinical practice. So we have raltegravir, we have elvitegravir, that's called first generation. Then we have second generation, dolutegravir and bictegravir, and also cabotegravir that is now been approved in several countries for long-acting treatment. But we also have oral drugs for the lead-in phase. We also have co-formulation of these compounds associated usually with NRTIs or NRTIs, as in the case of dolutegravir with rilpivirine. Just to briefly go through the idea of why are they used and how often they use it, as you can see, some of the largest guidelines suggest as first line the use of regimens that include integrase inhibitors. And this is mostly due because of their efficacy and tolerability. So almost all over the world, they're somehow being the first line, even in limited resource countries in which there's still some countries going for efavirenz 400 milligrams or dolutegravir. As I mentioned, just to give you an idea of the comparisons of these new drugs without the compounds, you see that there is either non-inferiority or favor the integrase inhibitors based regimens. So in the end, these are the core data that allow them to be in first line for the majority of guidelines. However, there are still some potential concerns, including the use of raltegravir, for example, that is a very well-tolerated drug, but it's still at least two drugs, either once a day or twice a day. There are some lack of data in certain patients, including pregnancy, for example, for the new formulation. Elvitegravir, we know that it's co-formulated cobicistat, so we'll just take a brief look at drug-drug interaction. Dolutegravir, there are two major concerns, that is safety conception. There's still this ongoing data on neurotube defects, very low prevalence in the last analysis in April 2020, but we'll take a look at that. And also neuropsychiatric side effects. For bictegravir, we have just few data, and so far it's just available at STR, so we're not able to, let's say, tailor it dose or even way of administration over time. Well, as for the pharmacokinetic properties, you see here the dose, so how it is dosed, the half-life, and I wanted to show you that the drug with the longest half-life orally given is actually cabotegravir, that even orally is a half-life of 40 hours. But then if you see the long-acting cabotegravir as a half-life, it might change in different studies, but it's between 25 and 54 days, not hours. So it's much longer. However, almost all of these drugs are highly proton bound. So it means that the percentage of the drug that is available for metabolization transport is very, very small. The exception is raltegravir, that is 83% bound. So there's a free raltegravir is much higher than the other compounds. It's relevant for DDIs, so it's for drug-drug interaction, the metabolism. As you can see, most of them are glucurinated through EGT1A1. But some of them, including elvitegravir, mostly CYP3A4, but also bictegravir, are metabolized by hepatic cytochromes, so CYP3A4. So DDI profiles varies a little bit. There might be also some effect on transporters, but so far they're deemed to be less relevant for clinical practice. There are just a few data suggesting a PK/PD effect, so higher concentration, better effect in clinical practice. There might be for raltegravir when it's given at just once daily, but the old formulation, we don't have much data apart from that. And there's one single study on dolutegravir suggesting that in patients that already have integrase resistant associated mutations might benefit of higher exposure. But in the global data that we have now, they're effective and well tolerated. However, there might be a difference in terms of inhibitory quotients. So how much drug is above the protein-adjusted IC90 or IC95? And in this setting, you see that both dolutegravir and bictegravir are much higher. So usually at the normal dose, we see that the C trough is between 16 and 17 times above the protein-adjusted IC90. So there's a lot of margin of safety in this setting. There's also a difference in terms of activity against INSTI-resistant mutants. As you can see, the drug with the highest potential for inhibiting resistant mutants is bictegravir, followed by dolu, then capotega, and then first generation integrase inhibitors. On the other hand, there might be some effect in terms of higher exposure to some toxicity effect. I just listed here some of the evidence. It's not much actually, because tolerability is usually good. We know that neuropsychiatric symptoms might be linked to dose and genetics, and weight gain so far, we don't have much of understanding of how important it is in different population, how much is it linked to drug exposure. I just wanted to list here all the evidence suggesting that higher exposure of dolutegravir are associated with more prevalent neuropsychiatric side effects, such as headache, insomnia, and neuropsychiatric effects. There's some evidence. There's one paper, for example, here listed in the graph by Japanese authors suggesting there's a difference. There's one interesting French case in which reducing a dose, so giving dolutegravir every other day, was useful in one single patient, and it decreased the rate of side effects. However, there are also some evidence from clinical trials, also from cohort studies, suggesting there's no link, and maybe genetics might be important, but we still don't know. So the family is there, but it seems to be not so frequent, and we still don't know if the dose matters. However, one of the things that might change the exposure of these drugs is age. We know that with advanced age, most of the patients might have adverse effects. We don't know if it because of pharmacodynamic changes or pharmacokinetic changes. Our group recently published the effect of age on dolutegravir exposure in plasma and cerebrospinal fluid, and there's a mild effect actually. The effect was more pronounced in the Cmax, so there might be a higher absorption in the first few hours after the drug is taken, but also there was an effect in CSF. So older patients, this is above 50, have a higher CSF to plasma ratio and also CSF concentration of dolutegravir. But we don't know if it matters clinically. And in this cohort, there were not much of side effects. However, our perpetrators, all these drugs have a low potential for being the perpetrators of drug-drug interaction. One of the targets is OCT blockade. We know that creatinine is actually transported by OCT2, and so there might be an effect in a slight increase in creatinine. Apart from that, we don't have much effect in this case. Another drug that is transported by OCT2 is metformin. And we know that there's a small increase in serum metformin levels in dolutegravir, patient receiving dolutegravir. The effect is much smaller in patient receiving bictegravir. However, there are also some clinical reports suggesting that there is not much of an effect on glycemia or other measures of the efficacy of the treatment. So probably it's not clinically relevant. This is the data suggesting bictegravir, the AUC of metformin is 39% higher, and so deemed not clinically relevant. However, integrase inhibitors might be victim of drug-drug interaction, and some of them are related to absorption. They are very sensitive to chelation by divalent cations, such as magnesium, calcium, aluminum, and iron. And so there are very strict recommendations suggesting how to take these supplements, including antacids, including aluminum antacids, calcium antacids, calcium supplementation, iron supplementation, magnesium supplementation, polyvitamins. As you can see here, most of them suggest to stagger the dose, so either 2 hours before or 4 hours after. However, some of the data suggests that if you take both things with food, the effect is below 30%, and so there's not much of an effect. It can be relevant for patients already having mutations, indeed. We know that another important thing is what happens with strong inducers. Think of rifampicin, so patients that need to take antitubercular treatment, or other, for example, anticonvulsants that are really inducing a lot of C3-4 and UGT1 and 1. Well, we have data suggesting elbapectin is contraindicated. big tegavir is contraindicated also for the effect on TAF. Capotega is contraindicated because I will show you afterwards the data on long-acting drugs. And now we have raltegravir and dolutegravir are two most popular options. In both cases, the final suggestion is to double the dose, and we are probably on the safe side. So these are the study on dolutegravir. As you can see, this is the effect of dolutegravir with rifampicin versus efavirenz. You see there's not much of an effect on biological suppression. And actually in the per protocol analysis, there was absolutely no difference at all. However, there's already some cohorts from some countries in Africa in which patients were taking dolutegravir once daily, and there were no difference in treatment success rate in terms of treating HIV or treating tuberculosis. So probably in patients already with virological suppression, 50 milligrams QD could be enough. But at this time point, we're using double dose, and we know we have good results with that. We have less data on moderate inducers. For example, rifabutin, that is a drug we use sometimes for treating NTM or when rifampicin is not tolerated. There's some very important blood-brain interaction. As you can see, the effect is very different. So raltegravir is not much of an effect. Dolutegravir is really minimal. But for example, elvategravir, cobicistan, and big tegavir are not suggested to be administered with rifabutin. So we might use it probably with ral and dolutegravir. We don't know much about cabotegravir. There's also some data about CYP3A4 inhibitors. So what should we do when we have drugs that may inhibit CYP3A4? For example, atazanavir, another protease inhibitor, or other compounds that may be blocker of CYP3A4. Well, it depends on how much of the drug is metabolized by CYP3A4. In this case, raltegravir is not. Dolutegravir is just minimally, approximately 10%. And so, as you can see, the drug is more metabolized by CYP3A4, so big tegavir had the highest effect. So probably we should be careful. We haven't seen a sign for higher exposure of big tegavir and side effects. So probably this may not be that clinically relevant, but probably be cautious in these settings. In this case, this could be important. Additionally, there is specific interaction for elvategravir cobicistat because cobicistat is a CYP3A4 PGP OATP inhibitor. So there are a lot of drug classes that are not indicated with cobicistat. As you can see the list, I don't want to go through them. I just want to mention that some of the most studied side effects in clinical practice are those with corticosteroids. With not only oral intravenous corticosteroids, there are a lot of clinical cases suggesting Cushing syndrome in patients receiving fluticasone or budesonide or triamcinolone. You use it intranasal, cutaneous, or intraarticular because cobicistat can inhibit the hepatic metabolism. So AUC are really several times, up to 300 times higher. And so the drug can stay there for weeks and months and then generating Cushing syndrome. So be careful when using cobicistat with corticosteroids. However, we are lucky to have a few resources, including the Liverpool website. There's other sites such as this one. It's called a DDI predictor that actually helps us in quantifying a potential interaction. So telling us if the prediction is like 10%, 20%, 50 or 100%, that helps us making decision in case that we don't have a clear pattern. For Liverpool website that is actually the gold standard for DDIs. I want to move briefly on what we know in clinical pharmacology of long-acting cabotegravir, just starting for the data of the registration studies, so phase 2, phase 3 studies, suggesting that given the two drug long-acting intramuscular given every month or every 2 months, and the first two studies are every month against oral drugs. And the last study, Atlas 2, recently published, there's a comparison between people already suppressed on long-acting drugs. They're randomized to receive the drug every month, every 2 months, while there is no signal of incomplete viral suppression. So it seems to be pretty fair in terms of efficacy. However, some of the concerns are that we don't know very well now the clinical pharmacology of these drugs and potential. There were just very few failures with the selection resistance. It's approximately around 1.8% in all the trials. well, surgical failure, and were only between 10 and 10, around 10 patients with a selection resistance associated mutation. So we still don't know the risk factors. We know, for example, that pre-existing mutation for rilpivirine could be the subtype A, could be a risk factor. There's some concerns about high BMI. High BMI can actually tell us that the needle is too small, and so probably the drug is subcutaneously administered instead of intramuscularly or in subcutaneous fat, and that might change actually the rate of the delivery of the drug. This might be most relevant in the first weeks. As you can see here, this has the PK profile of cabotegravir in the left in two studies, Atlas and Flare, and rilpivirine in the right panels. As you can see, the nadir concentration of both drugs is usually at week 8, even if a loading dose is given. And here there are in blue and purple and red and green in two different studies, the PK profile of patients that failed. What should you see that, for example, in Atlas study, there were 2 patients with low, so around in the 10 lowest percentile of concentration at week 8, but not in Flare. Also, rilpivirine was low in some of these patients. Well, actually, 3 out of 4 failures were female with a BMI above 30. So it was actually, it's still a concern that can be a combination of factor, pre-existing NRTI mutation, subtype A, and high BMI. This is important for 2 things. The first thing is the tail. So what happens when a patient doesn't come up for the next injection? We know that the tail is very long, and the drugs, long-acting cabotegravir and rilpivirine, and mostly cabotegravir, that has the longest half-life, might persist for up to 1 year. And so that me actually worrisome in terms of selecting resistance associated mutations, but also for what to do in case they come back. So if, for example, they just skip 1 dose, and we want to recontact them, and we are able to contact them, and they come back to the clinic, so what to do? What are done some modeling suggesting us what to do. We can give us oral drugs. They might have oral emergency drugs just to bridge for the period where they not be able to receive the injection. Or we might take a look on the PK, or we have some standardized here in the table on the left idea of how much drug given. So the loading dose or just a normal 400 or 600 milligram dose. It depends actually on after how many injection, as you saw in the previous slide, with ongoing injections, you will reach a steady state. So the trough concentration is usually higher. So after 3 to 4 injections, we have much more forgiveness. So even if patients present 7, 14, 21 days afterwards, the PK is still very good. The most critical phase are the first 2 injections, in which the nadir, the trough concentration is very low, so we might be worried about having very low concentration. After that, we might have a few days, even weeks of delay without pharmacologically based actually concerns. The last point about long-acting integrase inhibitors is drug-drug interaction. So we know that we actually skip the gastrointestinal tract. So the interaction we discussed before about absorption, so polyvalent vitamins, divalent cations are not here because no absorption. And also some of the interaction can be reduced because we skip the cytochromes and transporters that are present in the gut. So we just go through the muscle in the systemic circulation. So we don't have data, but there's modeling done by the group in Liverpool that I think is very interesting. As you can see here, the modeling of the effect of rifampicin with oral cabotegravir suggests a reduction is about 60%. You see here the orange line is much smaller, and from what we know now, we cannot co-administer oral cabotegravir and rifampicin. But the simulation of long-acting cabotegravir with rifampicin suggests there is still an effect that is between 30 and 40% at maximum. So let's say 30% in AUC. So it's much smaller. We still don't know if it's clinically relevant. So I believe that at this time point, we should not administer long-acting cabotegravir with rifampicin, but it tells us that DDIS profiles may vary according to the route of administration. And that would be probably very important in the future for studying this interaction. Another thing that will be important for us will be the monitoring. So how many times people have to come to the clinic, because the injection should be given in the clinic. So this is a brief scheme to suggest that since they have to come at time 0, 1 month, 2 months, and then every month or every 2 months, it depends on how we need to organize our service and when to perform virological, maybe deep virological analysis. So far, there is no indication for checking for drug-drug interaction and therapeutic drug monitoring at this time point. We just try to avoid the drugs that we know may interact in terms of important interaction. So in conclusion, integrase inhibitors are well tolerated, efficacious. They're in first line in almost all guidelines. They have a very small potential for drug interaction, yet some unexpected might occur. So we should just take a look at what happened. And we don't know what happened with complex interactions. So just 1, 2, 3 drugs together. How to manage the effect of potent inducers such as rifampicin is still under study. My personal view is that in naive patients, I always double the dose. In patients with a long-lasting suppression, I consider if doubling or not doubling the dose, according also to the number of pills they're taking and potential side effects. The clinical pharmacology of integrase inhibitors will be important also for reservoir controls in the future, that we're thinking of functional cure and medication. It will be very important to differentiate which drug is going better to lymph nodes, the gut, the brain, but I think it's speculation at the time. And in the end, long-acting drugs such as long-acting capotega, we still need more data about PK and certain risk groups, but we know that the potential for DDI is lower, and we need just to be vigilant and see what's going on with these new exciting drugs. I want to thank you for your attention, and it will be nice to answer any question if any.